Okay, thanks. I would like to thank HIMSS for inviting me to basically give you a brief speech about an ongoing experience. I wouldn't call it a success story yet. Let's see, maybe in 2 years it will be either a success story or a major failure. In any case, it will be interesting to look back to it. Where is Reggio Emilia? Reggio Emilia is up in northern Italy, in the Emilia region, near Bologna. It's a public hospital. The hospital I will talk to you about. It's focused on oncology, and it's accredited by OASI, and it's roughly 900 beds, which is medium to large size hospital for Italian standards. And it basically covers a population of 500,000 people, roughly. I'm a medical information systems manager with experience both in the public and the private sector. And I currently manage several IT systems in 2 major hospitals and 10 minor hospitals. The experience I'm going to talk to you about is about one of the 2 major hospitals. And I would like to tell you that I'm a biomedical engineer. I'm not an IT person by background. I've become an IT person, but my presentation will be mostly focused on a biomedical engineering perspective. And since the audience could have radiologists and should have radiologists, I will keep it simple from the technical point of view, okay? First of all, our hospital, it's an MRAM 6 score. I don't know if you are familiar with HIMSS MRAM score. It basically stages the EMR, electronic medical record adoption level. Level 6 is fairly high, higher than 6 is 7, basically. And we are pending confirmation visit. I must say this because we might be kicked out. But anyway, we've done a long path to get up to this level, and basically everything else that you might think of in the hospital, it's fully electronic. We've been fully filmless on the PACS side since 2003, and we have a fairly high level of IT investments. I'm telling you all this because the experience we are currently trying is very facilitated by all this. As I told you, I also manage other hospitals. It might be a different experience in other hospitals with a lower IT level. Well, basically, the path we've done in the last years, in the 1990s, we built infrastructure, then we built ADT, we built ancillaries, laboratory, risk packs, pathology, etc. In the year 2000s, we focused on MPI, repository order entry. This is a standard path for IT. And in around 2010, we started working on the EMR project, which is basically still ongoing, but at a very good stage. And what about now? Okay, according to the MRAM adoption score, we are about done, okay? So what's happening now? What's happening is that clinicians come to me on a, I wouldn't say daily, but weekly basis to ask me to manage their data, because there is still unmanaged data out there in my hospital. And I would call it residual data. What does it mean? They are minor sources in terms of amount of information, amount of data, highly specialized, and mostly media, images, video, data traces, which you see on video and they appear as videos, but as a matter of fact, they are data. And there's a whole lot of examples about this out there. And this is what I'm facing on a weekly basis, at least. Why are they emerging now? Okay, they are emerging because a major focus in our hospital, but in general healthcare, are clinical pathways. Clinical pathways require the sharing of information. And these clinicians, they are part of some pathway somewhere or another, and they want to share their data with their colleagues. Until a few years ago, they didn't actually need, because their data was their data. Everything they had to share was reports. Now they need to share data. Another issue that is coming up, at least in Italy, but from my colleagues in Europe, and it's coming everywhere, is regulatory aspects. Patients on paper, based on regulations, could ask us to give them their data at any time. And we are supposed to give them their data because we are supposed to store it properly. And this was on paper, on theory, until recently. And it's becoming more and more real. Patients come to us and ask us for their data, ask us for their images, for their videos, for their data, their traces. They want them. And we should be able to give them. Another issue is research. We are becoming, our hospital has become a research institution in 2011, and therefore for research we need evidence. We need to store the evidence in a proper way. As I told you, a modern clinical pathway requires referral from periphery to the competence center, to the central hospital, And referral means that not only the patient has to go, also his or her data has to go. Collective evaluation, many different people looking at the same data at the same time. Comparison of evidence from previous events or different patients with the same kind of issue. All this requires sharing data, not only radiology, all kinds of data. That's the major issue. Just to give you an idea, this is an example of oncology, a typical, if it exists, oncology pathway. It involves a whole series of people, like from the periphery hospital, from the general practitioner, the hub hospital, multidisciplinary team. And every step in this process needs evidence from previous steps. And every step could take place in completely different geographical locations. And the follow-up, which is the final step, can be very long and requires the gathering of all previous evidence. We did a study for an average colon ADK cancer patient. It would generate in his path over 300 pieces of evidence. Okay? Radiology is in there, but we also have endoscopy, you have surgery information, you have pathology information, all kinds of information. And that's average. So my issue now as an IT manager is that when this clinician comes to me, and of course he complains about the fact that I can't manage his data, it's a problem because he's small in terms of meaningfulness, so let's put it this way. But these clinicians are more and more. Taken as single problems, they are too small to be faced. But if I see them as a single problem that has a single solution, then it can be meaningful. And this is what we focused on. We wanted to have a solution that could actually solve this whole set of problems at once. Okay? Mainly for economical reasons. We need to buy only one thing that manages all of it. Because probably I could buy many different systems that manage ophthalmology, OBGYN, and EEG. I could buy all these systems, but if I sum up all the costs, they're not feasible. How big is this issue? Well, we did a study, a one-year survey sponsored by our PACS provider, and to basically see and gather all these potential media sources in our hospital and classify them, and we did a nice white paper on this. And basically what we found out is that there are 534 different data sources out there in our hospital that can range from very small devices, almost stupid devices, you would call them, up to very large systems like the motion gate analysis system, which is one single system that pumps out gigabytes of data at once. And all these systems presently are not really managed. As a matter of fact, what we did is we classified them, and only 13% of exams, 22% of devices are properly managed. Properly managed, it means that they are singularly properly managed. 8% of exams are improperly managed in the sense that they are stored somewhere but non-indexed out of regulations. They should not exist, okay? We found that they exist, but they shouldn't exist. And 79% of all these exams are not managed or not stored at all. I'm not talking about radiology, of course. Radiology is taken care of. This is everything else. Okay, so is the solution, well, when you go to radiology people, like people producing PACS systems, they basically say, okay, we've already solved this problem many years ago. It's radiology in a different setting. Not really. According to our experience, the issue is somehow different. This is the schedule workflow, radiological schedule workflow that everybody who works in radiology knows. This is taken from Wikipedia, by the way. And if we start sketching all the differences we find in the extra radiology world, we find that sometimes no image acquisition is scheduled. Image acquisition is done on the fly occasionally. And then you find out reporting is performed during acquisition, not after acquisition. And then you find out that sometimes you don't actually store the whole thing. You store electively some images only. And then you find out that sometimes there's preliminary reporting before acquisition, and the preliminary report actually guides the acquisition process. So basically, there are so many anomalies with respect to radiology, at least that we've found. So basically, this told us that this schedule workflow, the radiology world, is not really a good template to simply apply it to the extra radiology world. Plus, consider the fact that of all those 500 sources, DICOM is fairly rare. I mean, it's not everywhere, DICOM, in the X-ray radiology world. Okay, so what's coming from the radiologists, just to please the radiologists that are in here? Well, radiology has given us 20 years of experience, and probably more than 20 years, and it has given us motivation. They have managed properly data for so long, and they give us the proof that managing data is meaningful and can be done. And that's a big step. Second, radiology has built PACS infrastructure. Okay, all these companies working on PACS infrastructures, they've built the technical part. Now it's only a matter of adapting it. And something else, they gave us solid companies. We have big companies that have dealt with radiology, and they've saturated the market in radiology, I would say, at least in some areas. And they're now looking for some new challenges. And it's nice to have solid companies, big companies out there that want to face new challenges. Because on some problems, sometimes we can't find companies that actually want to solve problems. Okay, possible solutions. The radical approach is DICOM. Okay, let's DICOMize everything. Can be done, but it's not really the solution, especially because in many cases, original raw data has to be stored and shared. And this becomes an issue with DICOMization of secondary capture or other techniques. Then XDS comes into play. That's a standard that is beyond radiology. It's very stable. It's used here and there. On paper, it's the solution. But the issue is that it's rather difficult to ask a small company producing a very small device in a small number in small numbers to actually implement a full XDS interface. So what happened is that if we asked all our device producers to actually implement an XDS interface, some of them would be compliant. Many of them would simply tell us, no, it's too big of an investment. Either you pay all of it or simply forget it. So basically, what we played around is how about a simplified mixture of DICOM? It's OK to have a DICOM interface. It's great. XDS, and some very low-tech access, even proprietary. This is the solution we pursued, basically a solution of a multi-technology interface. Taking our survey, we basically found out that if we consider only DICOM interfaces, our system currently could manage 24% of the devices out there. If we went up to XDS, we reached 30%. 30% of all the devices out there means that I can't go to my management, top management, and ask them for the investment. Because I can't go there and tell them, OK, give me this amount of money. I'll solve 30% of the problem. They will ask me, what about the 70%, the remaining 70%? With what we call an XDS adapter system, which is basically low-level technologies, we basically gave an interface that could be used by 100% of the devices out there. So what are the present and future challenges of our project? We are gradually extending the number of data sources connected to our vendor-neutral archive. Of course, all DICOM sources were the first to be connected. They can be connected very easily. That's the legacy of radiology, the positive legacy of radiology. We are connecting them like crazy. But all other non-DICOM sources are gradually connected, either using XDS when they are XDS compliant or using these low-level technologies. We plan to connect all DICOM sources by the end of 2015 and all non-DICOM sources by the end of 2016. Basically, by the end of 2016, we will have basically all data sources in our hospital somehow properly stored. And the important thing is that any technology that we might buy, new technology, will have a menu, let's put it this way, of possible integration solutions within our hospital. So basically, we won't have anymore a solution that is acquired by our hospital and is still isolated. And that, going back to the clinical meaning, is we need to have the data flowing into clinical pathways because that's the current trend, and I guess it will be the future for some years coming. Okay, well, thank you for your attention, and of course, feel free to ask any questions.
Okay, if there's no question from the audience, I have only one question. What type of financial and clinical benefits do you expect by the end of 2016 when the full system is ready?
Well, the first aspect is going back to the three motivations. The first aspect is clinical. Currently, for clinical pathways, the clinicians have to electively store in some way the information they want to bring to the discussion, let's say, to the clinical discussion. From now on, they will have it online, properly stored in the system. The second aspect is regulatory. More and more, we are having patients coming to us to ask for the raw data. Just to give you an example, genetic information, genetic imaging, microscopy, genetic imaging is routinely done. If not properly managed, when the patient comes to us to ask for the original data, the original images, we cannot give them. And this can be an issue, and it has been an issue in our hospital because a patient asked for the original data. We could not provide it because it wasn't properly stored, and that is a major issue. And the third issue is, of course, research. And many different types of data are becoming input for oncology research and other kinds of research. So these are the main advantages. From a financial point of view, is simply a breakthrough in the sense that if we basically budgeted what was needed to solve all the issues one by one, we did this, this exercise, let's put it this way, the resulting amount was out of budget, completely out of any sense. Having a single solution that technically could solve all these issues opens the solution to actually to the real world.
We have one more question, and we can only take this one, then we don't have the time anymore. Yeah,
is there a financial exposure or liability to failure to meet your legal requirement if a patient requires?
This is a new issue, and in the sense that, at least in Italy, this regulation that actually required us to give the patient the original data in case he or she asked, has been in the regulations probably 10 to 15 years, but now, only now, they are starting to actually ask for it. And so basically, there have been some cases of legal, basically, hospitals being sued because they did not have the original data. So basically what we've been told by lawyers, who are always funny people, is that it's actually better to not store data at all. Because if the patient knows, and you tell the patient that their data is being stored, then you are required to store it properly. Okay? If you do an ultrasound to a patient, either you store it properly or you don't store it. Don't just assume that it's properly stored because it's in the hard drive of the ultrasound machine. Because when the patient comes to you, you have to be sure that that's his ultrasound properly stored. Because if something happens, then it would have been better to simply tell the patient this data is not stored. So lawyers can be funny, but if you think about it, it makes sense in some way.